Good afternoon, everyone. My name is Annette Johns, and I am the Deputy Registrar with the Newfoundland and Labrador College of Social Workers. I have the honor of being the moderator for today's education event, Harm Reduction and Addiction, Everyone Has a Role, along with my colleagues Kelly Keene with the College of Registered Nurses and Wanda Squires with the College of Licensed Practical Nurses. This webinar is a collaboration between our colleges. Today, believe it or not, marks 22 years of this wonderful partnership between our colleges to bring healthcare professionals together to raise awareness on a particular topic and to encourage thoughtful consideration and reflection. We have over 440 healthcare professionals registered for today's event, which is excellent. Before we get into the presentations, I do want to go through some housekeeping details. The panel presentation will be approximately an hour and a half, followed by a question and answer period that Kelly, Wanda, and I will moderate. So during the presentation, we encourage you to type in your questions using the question mark widget to the left of your screen at any time, and we'll begin asking them at the end of the presentations. To customize your viewing experience, you can resize and move around any of the elements you see on your screen. Also of note, the PDFs of today's presentations can be found under the resource section on the platform. Now on to today's topic. As healthcare professionals, we understand that illicit drug use is a complex health and social issue. Our panelists this afternoon will provide an overview of illicit drug use in Newfoundland and Labrador, including information on illicit drugs that are available in our communities, statistics on overdose deaths, and rates of hospital admissions due to illicit drug use. Our panelists will also provide information on the benefits of incorporating a harm reduction approach to service delivery while exploring some of the practice realities and ethical considerations. Regardless of your profession or area of practice, we hope this session reinforces your knowledge and understanding of harm reduction, provides some new learning or takeaways that you can incorporate into your own practice, and sparks continued conversations amongst colleagues and in the workplace. So on that note, I'm now going to turn things over to my colleague, Wanda, to introduce our wonderful panel for this afternoon.
Thanks, Annette. So we have an excellent panel lined up for you this afternoon, and their full bios can be accessed through the bio widget on the platform. However, I just want to take a moment to briefly introduce the panelists to you now. So we have Wayne Bishop, is a program manager with the Mental Health and Addictions Program, Newfoundland and Labrador Health Services in the Eastern Zone. We have Tammy Coffey-Hickey, who is a professional practice nursing consultant with Newfoundland and Labrador Health Services Eastern Urban Zone. We have Jane Henderson, is the provincial harm reduction consultant for the Newfoundland Labrador Centre on Substance Abuse. We have Shane Randall, is an epidemiologist with Public Health Agency of Canada. And we have Taylor O'Connor, who is a social worker, formerly with the Harm Reduction Outreach Team, Newfoundland Labrador Health Services, but now is the operations manager with the Primary Healthcare and Chronic Disease Prevention and Management Program. So we have a truly wonderful panel for you all, and I'm looking forward to the knowledge that will be provided by our presenters today. So without further ado, we're going to get this started, and I'm going to now invite Shane to come forward as our first presenter.
Hi, thanks so much. Can you hear me okay?
Yeah,
excellent.
Perfect.
All righty. So my name is Shane Randall. I'm a public health agency public health officer placed with the Office of the Chief Medical Examiner here in Newfoundland and Labrador, as well as with NLHS Digital Service, formerly NILCHI. So I'm going to give some fast and furious high-level stats today on hospitalizations and mortality concerning substances seen in Newfoundland and Labrador. And so today I'm going to focus mostly on, I'm seeing a preview on my slide now, but is everyone able to see my slide? My first time using this.
I can't see it, Shane.
You can't see?
You gotta hit next.
Yeah.
I did. There's a button, push to audience.
No, just go with the green.
I hit next for you.
Yeah.
Okay. Sorry. The pleasure of going first. Okay, now it says live. So I think people should be able to see it. Okay, so today I'm going to focus on 2018 to 2024 data. That's how far back our substance-related mortality database goes for now, although surveillance was happening in 2016 and 2017. And I'm going to mostly focus on opioid and stimulant-related data today. Okay, and I press next. Hopefully you can see. So my land acknowledgement. I respectfully acknowledge the land on which I work and live as the ancestral homelands of the Beothuk, whose culture has been lost forever and can never be recovered. I also acknowledge the island of Uktamaguk as the unceded traditional territory of the Beothuk and the Mi'kmaq, and I acknowledge Labrador as the traditional and ancestral homelands of the Innu of Nitassinan, the Inuit of Nunatsiavut, and the Inuit of Nanatukovut. Alrighty, so today I'm going to quickly go over basically who I am or why my role exists, and then talk a bit about substance-related harm surveillance in Newfoundland and Labrador. I'll give some specifics on hospitalization data as well as national drug seizure data. That's samples seized by the authorities such as RNC and RCMP and analyzed by Health Canada laboratory. I'll give an overview, very high level overview of mortality data for 2018 to 2024, and then give a very quick introduction to upgrades to our internal surveillance system and our proposed public facing system, which hopefully will go live this year. Alrighty, so my role as a public health officer working with this data. So I'm a part of the Public Health Agency of Canada, specifically underneath their Canadian Public Health Service, the CPHS. And CPHS was created in 2006 following the SARS breakout as a way to enhance surveillance and timely and accurate data reporting. And so it's very much so a response to what the current needs are. And then public health officers are placed in different jurisdictions across the country. I'm lucky enough that I get to work and live in the same place. So this is my home, and I'm very lucky to be able to work here. And so there are different streams within the CPHS. So for me, I was hired under the substance-related harms stream, which deals with the originally opioid-related surveillance, opioid mortality surveillance, but we've grown a lot since then, and we're adding to our surveillance model every day. Not every day, but quite regularly. I also serve under the public health death investigation stream, and the main point of that stream is to harmonize through a collaboration with chief coroners and chief medical examiners across the country in an effort to harmonize how they capture and how they report on their forensic death investigation data. And then there are other streams in this branch too, like the emerging priorities, vaccine surveillance, and these different streams are, as I said, needs based. So the vaccine surveillance, for example, that one is sunsetting and closing down. There was a COVID-19 stream. They're also closing down surveillance. So it's very much so needs based. Alrighty, so right into hospitalization data. So the hospitalization data we pull from the provincial discharge abstract database, and it's coded using ICD-10 CA codes. So we're able to pull quite readily information on a bunch of substance and self-harm related admissions. Today I'm going to focus mostly on stimulant and opioid related hospitalizations. Emergency medical services data, so our first responders data. My predecessor, Caddy, who's now in medical school, she did a phenomenal job starting this surveillance from the ground up with the chief medical examiner, and she previously was able to access paper charts for suspected opioid-related responses defined as the administration of naloxone as part of the call. And so the EMS data has recently gone digital, so we're hoping to be able to start again with the low-hanging fruit of suspected opioid-related responses using EMS data. And currently emergency department data, as it's not coded with ICD-10 CA codes, we can't, for now at least, I can't have access to emergency data. Alrighty, now this is a very busy slide, but again, for time, I wanted to take opioids and stimulant hospitalizations and put them all on one very busy graph just so we can kind of get the main point. Our blue line up here are opioid-related hospitalizations, and although maybe not significantly so, they do outnumber the total number of stimulant-related hospitalizations per year, which is our dark green line here. But interestingly enough, when we take the stimulant data and break it down to cocaine versus all other stimulant or psychostimulants, we can see the medium green line here, cocaine itself, except for 2020, contributes more to admissions than any other or than all other stimulants combined. And you'll see that come out as, I guess, one of our main points from this data. Cocaine definitely is one of the major players here in our province. I know the focus nationally has been on fentanyl and opioids, and they do play a very important role here, but we definitely have a standalone stimulant or cocaine issue in our province. And so I'd mentioned the drug analysis service data. That's Health Canada initiative. And so when an RCMP or an RNC officer seizes a sample on the street, it might be at a death scene, or it may be part of a drug bust, or it could just be part of any routine surveillance they're doing. But if they do seize a sample, it's sent to one of 3 Health Canada laboratories for substance identification. And our samples here in Newfoundland and Labrador go to Montreal's lab. And so there is public-facing reports available. I think these slides can be shared, so I've put the link there, and you can basically go there and filter the data for Canada, or by province, by region, by substances. And just for time today, I've pulled just 2024 data, just to kind of give a splash of what you can see there. I do receive raw data for community level seizures, but that's not for public disclosure. But I do use that to report back to the Department of Health and other authorities here. So it's nice that the authorities can provide this data, or provide the samples, and then they actually get the data back, which is really nice. Alrighty, so this is just, again, the most recent data from DAS. This is looking at Canada for 2024. So we had just under 98,000 samples seized, excluding cannabis. Cannabis has its own dedicated database. 60% in Canada of the samples seized had at least one stimulant, 23 had at least one opioid, and of those opioid samples, 27% contained a benzodiazepine as well. So when we look at Newfoundland's data, we had 896 samples analyzed, which was a 70% increase over the same period of 2023. I did notice in the fall of 2024, we did see quite an increase in the number of substances seized, sample seized, and the number of identified substances, as well as just more and more of the novel substances, which I'll talk about in just a few slides. So here in 2024, the sample seized, 51% had at least one stimulant, 28% had at least one opioid, and of those opioid samples, 15% had at least one benzodiazepine. Again, this is 2024 data. Please excuse my mistake down there. The black bar says most recent data was up to Q3, but this is actually data for the whole year of 2024 now for Newfoundland and Labrador. So when we look at the graph there, we can see cocaine by far outnumbers everything else with respect to what we're seeing in seized substances across the province. Methylphenidate being second, and then we have the 2 opioids, fentanyl and oxycodone, coming up there in 3rd and 4th place. I did want to bring your attention down to the blue benzodiazepines down here. So we do see clonazepam and other normal pharmaceutical benzos that you'd expect to see, lorazepam and such. But this one here, bromazolam, is an illicit designer benzodiazepine that's only been seen in the last few years. And unfortunately, it has made its way both in drug mortality, toxicology results, as well as the DAS data. We're seeing it here in Newfoundland and Labrador in the last couple of years. Alrighty, so I'd mentioned that the mortality data comes from our the OCME's data. So that's I guess previously it was captured in bits and pieces, but we've decided to put it into one dedicated provincial drug toxicity mortality database. And so it's a bit of a unique situation for me. I should be working with the OCME's data analyst, but I feel like I scared him away. He left not long after I started. They tell me it's not my fault, but since he left a couple of years ago, I've taken on, I guess, the acting role of data analyst, which is great in one way because I'm accessing everything I need. But it can be a little bit scary too, because sometimes there's not always somebody to go to make sure I'm doing something right. So I'm constantly consulting with my colleagues, like I said, the people smarter than me, to make sure I'm hopefully not doing anything wrong. But the indicators are basically abstracted from closed cases. So once the forensic death investigation is complete at the OCME and the case is closed, then it can come to me and I can abstract the data for provincial and national reporting. And the application would be for that timely, customized data reporting. We handle a lot of ad hoc data requests. This database feeds into multiple reporting tools as is, and hopefully soon we'll have the online public-facing OCME database I wanted to mention, which I'll mention at the end. It contributes to other policy driving dashboards and reports, and it's been used through collaboration with an LHS applied research team. We've been able to support data for action research using data from this database, as well as a suicide database. Alrighty, so the drug tax mortality database includes, but not limited to, data around demographics, full toxicology results, including substances that were detected versus those deemed by the pathologist or the medical examiner to have contributed directly to the death. We have geographic data on where the person lived, where the incident happened, the overdose incident happened, and then where they ultimately died. So a lot of the times, most cases, we're seeing people dying at home, overdosing and dying at their own home. But sometimes we might see somebody from Eastern who has an overdose event in St. Anthony, survives, and is moved to Corner Brook and then ultimately dies in hospital. So we can see that one case, then we're going to have not only 3 different geographies, but 3 different health zones involved with the one death. Alrighty, diving right into the mortality data. Just a disclaimer that the 2024 data that you see in the coming slides, that's open year data. So we're almost, I'd say we're rounding into the last of quarter 4 for 2024, but those numbers are still subject to change based on the final pending cases for the year. And the disclaimer is any data in these databases are subject to change as new information becomes available. Alrighty, so our first slide here, this is going to be the total number of overdose deaths or substance toxicity deaths going back to 2018, regardless of whether it was a suicide or deemed accidental. And even just looking at the total number of overdose deaths, we can see we started seeing a slight uptick in 2021. 2023 and 2024 have been record-breaking years, unfortunately. And as I said, 2024, we're still waiting for the final quarter cases to be finalized. So that number I expect will go up. I can't say to how much, but hopefully not too much more than that. But as you can see, we had quite a record-breaking year in 23 and 24. And here the blue bars are the exact same as the previous slide, so our total number of overdose deaths. And then we see in the orange bars the number of accidental deaths. And so when we look at 23 and 24 data, not only does the number go up, also the proportion of the deaths that are accidental goes up. So at least at the high level, we can suggest from just those basic trends that the increase in overdose deaths the last couple of years are mostly driven by not suicide with, say, antidepressant medications, but moreover, accidental deaths. And I mentioned keeping it mostly to opioids and stimulants for today. So I wanted to just, for those years, break down the number of opioids that we have, our blue line versus stimulant deaths. So that's where at least one stimulant and or at least one opioid contributed directly to death. And as with the admissions, up until 2023, at least, opioids were contributing to more deaths as a class compared to stimulants. But we met up in 2023, and so far for 2024, stimulants have overtaken opioids as the most commonly seen class. But the red line is actually where we're seeing both an opioid and a stimulant implicated in the same death. And as you can see, the last couple of years, that number has gone up a little bit as well. And one final breakdown for the mortality, I wanted to, everyone asks about fentanyl all the time. And as I mentioned, we do have quite a cocaine problem here in the province. So our blue line over the years is our deaths where cocaine directly contributed to deaths. And so we can see in 2022, we had 18 and then up to 34 and 37 so far for 2023 and 24 respectively. So quite a jump. I should also mention that from my colleagues in other jurisdictions, there seems to, in 2024, to have been a slight decrease in the number of drug toxicity deaths nationwide, but in some jurisdictions, us unfortunately being included, we're actually seeing the numbers go up in the last couple of years. Our green line, fentanyl and or a fentanyl analog, so that might include parafluorofentanyl. It's a case where at least fentanyl, and in some cases fentanyl and a fentanyl analog, were implicated in the same death. And so as you can see over the last few years, very few deaths per year. However, in 23, we went up to 9, and so far, 2024, we have 18. So we've tripled 2021 numbers already, unfortunately. And then with respect to deaths where cocaine and fentanyl and or fentanyl analog were both implicated in the same death. You can see they're quite rare, but we've had 7 in the last 2 years each. Ethanol, as a monosubstance, we do see ethanol detected quite frequently in drug tax deaths. It does contribute. We see sometimes if there's a high level of alcohol and cocaine, we get cocaethylene, a metabolite where both kind of fuse together, and that substance, cocaethylene itself, can be more toxic to the body than just the parent substance. But with respect to alcohol poisonings or monosubstance alcohol deaths, they've maintained stability over the last few years, less than 10 annually. Benzodiazepines, however, unfortunately, are increasingly seen in contributing to drug tax deaths in Newfoundland and Labrador, as well as the rest of Canada. In 21 and 22, we had 6 cases each. So far for 23 and 24, we're seeing 15 and 18 deaths where at least one benzo by itself or in mixture with other substances directly contributed to death. And I mentioned we're seeing more and more novel substances. So previously, in so many years, we've seen carfentanil and isotonitazine. Carfentanil being a very potent fentanyl analog, isotonitazine being a very potent synthetic opioid, and also etizolam, bromazolam, and fluoprazolam. So different illicit benzodiazepines as well. We saw our first couple of cases of bromazolam in a death at the end of 2022, with multiple more, unfortunately, in 23 and into 24. In 23 and 24, we also saw parafluorofentanyl, orthomethylfentanyl, and acetylfentanyl for the first times in our province. And in 2024, we also had a handful of cases with xylazine, which cropped up across the country. And as with Newfoundland and Labrador, we usually get it blows west. It blows from the west eventually, unfortunately. So yeah, the main story would be we are seeing an increase in our drug tax deaths, and we're seeing an increase in what we're seeing in those deaths as well. Not only in the deaths, but what we're seeing in the streets from the Drug Analysis Service data. A couple of more slides really quickly. All of this work from these databases are currently feeding into our mental health and addictions internal surveillance system, with plans over the next year or so to greatly enhance what that includes for our internal stakeholders. So my colleagues Wayne and Jane know all about that dashboard, and hopefully good things to come for that one. As I mentioned, we're looking forward to hopefully this year having a public-facing OCME data hub going live. So that would be all stats, all cause mortality from the OCME, and then this system is continuously used to answer to ad hoc data requests, which hopefully the public-facing data hub should be able to alleviate some of those requests once that goes live. And then, so the mental health and addiction surveillance system basically is pulling data from multiple sources, including suicide and drug tax mortality from the OCME, hospitalizations and admissions data from NLHS, as well as EMS data. Internally, we also do pharmacy reporting for opioid dependency treatment and alcohol use disorder therapies, as well as naloxone distribution sites. We also pull from the Health Canada Drug Analysis Service database, and we also have some other mental health and addictions indicators that were previously reported that are under consultation to see if the validity is there to continue with those indicators, or to see if they need to change them, as well as considering some new and emerging indicators that we'd like to add as well. And so then once our OCME data hub is public facing, I know that's not the end, that's the beginning, because then that's when all the feedback will come in, and we're hoping that this will be able to pivot over time based on the needs that come up. But as I mentioned, that'll be all statistics from the OCME, including natural cause, but then we would have suicide and drug tax deaths as standalone or breakout dashboards with resources for anyone from media to just anyone in the community that wants to have access to that information, as well as a one-stop shop, hopefully, for the resources that might come in handy as well. Alrighty, so I think that's pretty much it for me. Thank you very much. I'm sorry if I went a few minutes over, but I think I'm going to hand it off to Jane next.
Thank you, Shane Zwanda here. So that was a very interesting presentation with lots of stats for sure. So I'm going to hand it over to Jane now to continue on with our presentation.
Hi, thanks. Can everyone hear me, I assume? Good afternoon. So I'm Jane. I am the Provincial Harm Reduction Consultant with Newfoundland and Labrador Centre on Substance Use. This is the Harm Reduction 101 in a much more condensed version. Yeah, we'll try to get through the slides I have here. So I wanted to give you guys a visual after what Shane went through with the numbers. Can you guys see on my screen now? It says preview. I'm assuming that's still fine. I'm just going to keep talking until someone interrupts and says it's not. So I wanted to give you guys a visual of what 40,000 people look like. And this is the actual number of folks that have died in Canada between January 2016 and March 2023. And this, of course, is a stadium that represents 40,000 people. So that's just the number of folks who've died from opioid toxicity deaths. When we look at the numbers up to 2024, we're up to 48,000. So certainly this is absolutely a crisis. When we compare these numbers to, say, the COVID deaths over the years that we've been struggling with COVID, the numbers are very similar, but we kind of think about our public health response to COVID versus our public health response to folks dying from substance use. It's very different approaches and attention, I guess I should say. So it's estimated that 21% of the Canadian population will actually meet the criteria for addiction in their lifetime, which is really 1 in 5. And a lot of folks don't know that. And what I say to folks when I'm doing webinars and stuff like this is, in any sort of, if I have 20 people in the room, I'll say, okay, statistically speaking, around 4 to 5 people are here are actually going to have meet the criteria for addiction. And certainly if it's not you, it's probably someone that we care very deeply about. So I guess the point is that, a lot of us have been touched by addiction in many different ways. So there's 47,000 deaths linked to substance use annually. Alcohol is still the most commonly used substance. We have 19% of Canadians aged 12 and over actually report a consumption that would classify them as heavy drinkers. Cannabis is quickly catching up at 17%. We've certainly seen an increase in cannabis lately. And opiates are about 8%. And like Shane said, we're seeing stimulants, of course, taking up that space. So what is substance use? Substance use is simply the use of substances. If you're drinking a coffee right now, you're actually using a substance. So it refers to the use of drugs or alcohol, right? It includes cigarettes, illegal drugs, inhalants, and solvents. There's a billion definitions of dependence, guys, but generally what most people agree on is that dependence occurs when someone needs a frequent, repeated dose of a substance to make them feel normal. And this is really hard for those of us who've never had to really deal with this. And, when I first started working as an addictions counselor, I remember people saying, in the morning they had to wake up and they had to have a couple of beer just to get started at the day, or have a joint or have a hit or whatever. I remember thinking, wow, that's so odd. Like, I can't imagine having to get up and do that. But overwhelmingly, that's what clients have told me, that they needed this amount of substance just to make them feel like a baseline of wellness, right? So the DSM, the Diagnostic Statistic Manual, I'm sure a lot of you guys are familiar with that. That is kind of, especially for us counselors, that was kind of our Bible in how we diagnose and how we treat and work with folks with mental health and addiction issues. So they define addiction as a chronic relapsing disorder that is characterized by compulsive drug seeking and continued use despite harmful consequences and long-lasting changes to the brain. It's considered both a complex brain disorder and a mental illness. So I always put this up here because I want people really to think about that. So these DSM, written by very smart people, doctors, people in this, it's backed by the Surgeon General. Like it's certainly, it has the book itself has a lot of integrity, and they say that substance use is going to continue despite harmful consequences. So what I say to people is, if we believe that substance use is going to continue despite harmful consequences, then maybe we should look at our primary response to substance use, and that is typically more harmful consequences on people. I've talked to judges. I've been in front of judges with young people before. And, a lot of what I say is I've seen a lot of good people do bad things. And certainly when someone is in the throes of addiction, it's a very chaotic lifestyle. And they really, they become, many people say the brain becomes hijacked. They do things that they normally wouldn't do when they're looking to get their substance of choice. And many times when they go in front of a judge, this will be brought to the judge, and the judge will say, okay, well, I'm going to release you today, but the condition of your release is that you can't use anymore, or you can't be around people who use even more, people who use as well. But, that's really going against what we know about addiction. We know that addiction is going to continue to be used despite harmful consequences. And, if a judge or anyone or me or you or anyone else could order someone into abstinence, then probably a lot of us wouldn't be in this position. Okay, they're telling me just press green button. We don't have control of the webinar. I don't see the green button, guys. Okay, I just hit next. Can you see the next one? Yes. Okay. Okay, so there's actually a continuum of substance use. There's folks who fall in the category of non-use. To be honest, I haven't really met anyone who's never ever used a substance, unless they're probably like a baby, considering that caffeine is a substance. Yeah. And then there's beneficial use, and that's use that's considered beneficial to the person. And it really has no harmful effects on society. So that is, if you're taking a medication as prescribed, that sort of thing. And then there's lower risk, and that's kind of where most people fall in. And lower risk is use that has minimal impact on the person and society, right? So that's if you're going out for dinner and you're having a couple of drinks and you're leaving it at that, you're getting a cab, you're going home, no big deal. And then there's higher risk use, and that's when your use is starting to become more habitual, right? And that's when you're starting to see negative consequences in your lives, right? So that could be harmful routes of administration. If you're using injection drugs, it can be binge drinking, it can be drinking and driving, it can be, even getting in fights downtown, right? All of that can fall under high risk use. The use is starting to have negative impacts on you and people around you. And then there's substance use disorder or addiction. And that tends to be where a lot of us spend our time. That's where I have spent most of my career, is working with folks with substance use disorder. And again, the definition we just learned is that is a treatable medical condition that affects the brain and involves compulsive and continuous use despite those negative consequences, right? And this is frustrating, guys, because we're in this field because we care very deeply about the people that we work with. And when we see them using, we see that drug as a bad thing, right? And we feel that if we could just take away that drug from them, that everything would, be better for them. But I want to tell you a little story about what challenged my kind of thought process on this. Several years ago, I had a client, and he came to me, and he had very intelligent man, and he had lost his wife, his kids, his car, his house, his dog. He lost everything. And he was actually using an 8 ball of cocaine a day. So when I met him, I was like, okay, this guy absolutely has substance use disorder. He's lost everything. This has affected him. It's affected his family. It's, essentially ruining his life. So anyways, we, did all the things that we do, and we went through the plans and all this sort of stuff. And I banged into him sometime later, and he approached me, and we were talking, and I was like, man, I was so worried about you. You were using all that cocaine, and he said, Jane, he said, the only thing that kept me alive during that period of my life was cocaine. And I was kind of like, I was really shocked by that, right? And I said, what do you mean? He said, the only reason why I didn't kill myself during that time in my life was cocaine, right? And as I got more and more into this work, and I've been in this work 20, how old am I? Yeah. So I've been in this work over 20 years. I've learned that overwhelmingly the people that I've worked with, especially those with chronic substance use or substance use disorder, are doing so in an effort to manage a trauma, right? So the point here is that you can have addiction, but make no mistake, for many folks, that addiction is providing them with something. So if I had had a magic wand and I could have taken away that gram of cocaine from him and then thought everything would be great again, he says he would have killed himself, right? So it's about understanding more of the process of this, right? So what is harm reduction? Harm reduction is just a philosophy, guys. It's many of you are using harm reduction every day, right? So it's just a philosophy that includes a range of support services and strategies to enhance knowledge, skills, and resources, just with the aim of keeping people safe and minimizing disease and death from high-risk behaviors. So what I say when I'm live with folks is I say, okay, well, how did you get to work today? And, how do you guys, get to the mall? How do you get to soccer practice or whatever? And the majority of folks drive. And I say, okay, well, what is the first thing you do when you sit in your car in the morning, right? The first thing you do, it comes second nature to us all, is we put on our seatbelts, right? So using a seatbelt is absolutely harm reduction, because driving is a high risk behavior, right? So in order to mitigate those risks and mitigate those potential harms, we have seatbelts, we have side impact beams, we have airbags, we have speed laws, we have speed bumps, we have all this sort of stuff because we're trying to mitigate the harms. We're not saying that, people can't drive anymore. We're saying here are some things that we're going to put in place that we can help make it safer for you to do so. And it's very similar to that when we talk about drug use. So harm reduction acknowledges, push the audience. Harm reduction acknowledges that high-risk behaviors occur and often chronic and ambivalent to change. And again, that's really tough for us. Those of us, we care very deeply about our patients. And, we can't understand sometimes why they can't change. Like, why are you still doing this, right? I worked at this program when I was at Choices for Youth. I worked at this program called Mama Moments, and we supported young pregnant and parenting moms. And I remember when I first went to meet the moms, the ED said to me, he said, Jane, he said, we got 19 moms right now. He said, but they all have children. It was like, I can't remember how many guys. It was something like, there's 28 kids involved with these 19 moms. He said, but the majority of those children are in care, and they've been many times, unfortunately, apprehended from their parents. And I remember, and this was due largely to the drug use of the mother, right? And the kind of chaos that comes with that, right? Because it can be very chaotic, right? And I remember thinking to myself as a parent, my God, like there's no way anyone, that would happen to me. Like, if I had to never to have a drink again, but have my children, I would absolutely do that. And it was almost kind of saying, how dare they? Like, how do they do that? Like, don't they love their kids? And I remember when I met the moms, my thoughts changed very quickly. And I remember thinking, my God, these mothers love their kids just as much as I love mine. And there was something much larger going on, than the simple, just not loving someone enough to make a change, right? So harm reduction also recognizes that individuals are experts in their own lives. It recognizes that absence is not always realistic or desired. I think most people are looking to live healthier and maybe looking into recovery, but it's not always realistic for folks at certain times in their lives, right? It involves a bunch of different strategies. It can be integrated programs, policies, and practices. And it's actually part of the 4 pillars we use to address substance use. So harm reduction goes along with enforcement, prevention, and treatment. If you guys were live now, I'd quiz you guys and say, how much money do you guys think that we spend annually on substance use? And then I would shame everyone when they didn't say a high enough number. I'm just kidding. So when we look at like lost productivity and the cost of substance use and what it's actually costing society, it's about $40 billion, right? And out of these 4 pillars, just think about which one do you think has the most funding devoted to it, which takes up the most funding. It's right here in enforcement. So about 75% of all money is dedicated to substance use disorder is actually going to enforcement. So that's the incarceration, criminal justice, all those kinds of things are very, very expensive in society. Okay, next one. So again, I worked at this place called Choices for Youth. And one day the ED and I were sitting down and we were doing our annual general report. And we kind of always worked in a harm reduction manner, which I suspect a lot of you folks do. But he came up with this definition. I really love this definition. It says, in the absence of perfect choices, we help people choose the one that causes the least harm. We do this so that we have the opportunity to work with folks again tomorrow. And I love this definition because it talks about the absence of perfect choices, right? So when I first started in this career, we're all human. We all have our own egos. We all have our own worldview. And sometimes it's hard to put ourselves in other people's positions. And we kind of think that the decisions that we make would be the same ones that they make, when really it's quite different. One of the first lessons I learned is that the people that I work with do not have the same choices in front of them that I've had in front of me, right? So the people I've worked with have had poor, and really poor decisions in front of them, or choices in front of them, right? And when they choose that option that causes them the least harm in their life, it still might be a very poor choice, right? But it's the least poor of all of them for that person right now. And there's a saying that you don't make good choices, you have good choices. And so many of the folks that I worked have not had those good choices in front of them. So harm reduction really, and I say this a lot when I'm working with folks in healthcare, is that accessing proper healthcare to live healthier should not depend on a person's ability or desire to achieve sobriety. And I think that's sometimes, sorry, I forgot to push that to you guys. Sometimes we kind of mix those up too, and this is not about responsibility. This is not about like all that sort of stuff, accountability, motivation, all this sort of stuff. but someone's ability or desire to achieve sobriety should not affect whether they can access proper healthcare to live healthier, right? So how does harm reduction improve relationships with people? Well, I can honestly tell you that once we adopt a harm reduction approach, we really start to have more meaningful relationships with people, right? When we create safety, control, and connection with folks, we can start to do some really great work. It leads to greater healthcare, as most people are more likely to engage in services, and it's really mutually beneficial, because what I find is that when we start working from a harm reduction manner and not a punitive one, we actually get to understand what's really happening in people's lives, right? So we actually get to know the conditions of their use, right? So once we understand exactly what's going on, their challenges and their barriers and all that stuff, we can help them navigate that better, right? But when we don't know what's happening, we don't know what's happening. People are afraid to talk to us, then we're not going to know. So what's happening in Newfoundland? We've got lots of cool stuff happening in harm reduction. We have where I work, we have the ODT hubs, we have naloxone distribution, we have SWAP, recovery center doorways. Lots of family doctors now are jumping on harm reduction. There's no special authorization required for methadone and Suboxone. Lots of peer support, and we have some cool pilot projects. We also have the harm reduction team, which I will scream from the rooftops about how fabulous they are. They're based out of 50 Monday Pond Road. They have one nurse practitioner. I think they have 6 nurses now, a pharmacist, an OT, and a social worker. And they have a drop-in every day from 1 to 4, and they are fabulous. Love to see them expand across the province. Okay, so I don't have time to go through all of this. So I just kind of cherry-picked a couple of ones that I really liked. So harm reduction is pragmatic. We have done everything we can to stop substance use. We've had prohibition, we've had a war on drugs, we've had all these laws, we have all of this, but people are still going to use substances. So the pragmatic response is saying, okay, if people are going to use substances as a public health response, how can we keep them safer, right? It's pragmatic. And harm reduction also focuses on harms, right? And many times, we've had clients who have had some drug use or harmful routes of administration. Many times they get like abscesses on their arms. And I remember at Choices for Youth, we had to take a lot of young people to the hospital with that, and the first thing they would do is they get to the hospital that have a large abscess, that have track marks, they're in active use. And they'd finally wait and see the doctor, and they get to the doctor, and the doctor would say, well, you're using drugs, you got to stop using drugs, right? So the idea around harm reduction is we can stop that just right now. That's not to say we can't have really great conversations around, the harms associated with certain drugs, about overdose prevention, about naloxone, about all this good stuff, even about treatment. If the client wants to talk about it, the patient wants to talk about that. But harm reduction focuses on the harms, right? Not the actual substance use itself, right? I think Taylor said she's going to be doing some of this, so I'm just going to skip right on through to the next one. Guys, it's really important that we have non-judgmental care. And I will tell you, when I first started working, I honestly thought I am the most non-judgmental person ever. I treat everyone the same. I got this all figured out. In my career, this has been challenged. I've certainly been challenged with this. And I say, when I was, again, at Choices for Youth, I remember one time I saw a very, very pregnant woman smoking. And she was young, actually about 19. And she was like 8 months pregnant. She was smoking. I remember going, oh my God, like, does anyone talk to her about this? Like, this is not okay. Like, she can't be smoking and pregnant. And, this is so harmful for the baby. And it came out of a place of caring, I think. I didn't mean to be judgmental, but it came out of like, this is not good. I remember I went to one of the coordinators. I said, someone needs to talk to that young lady about the harms of smoking and pregnancy. And the coordinator looked at me. She said, Jane, 3 months ago, that young woman was in hospital for infective endocarditis. In the past 3 months, she's come off heroin. She's had a valve replacement. She's left an abusive relationship. She's found safe housing, and she's getting prenatal care. So we're just going to let her have her smoke right now. And I remember thinking, I'm an idiot. Of course, we're going to let her have her smoke. And that's not to say that we can't let her know that, here's what you need to think about now. Like, these are the things that could happen. How can I help you? Do you want to talk about, cessation and all that sort of stuff? But my immediate response was judging her. And even today, like, if I'm driving down the road and I see someone smoking and they got kids in the car, like, I kind of cringe a little. My dad died of lung cancer. So I'm kind of like, oh, but I have committed to recognizing that is something that I have. Like, I'm probably always going to cringe. But I have committed that will never, ever get in the way of me giving the services that I need to someone, right? I'm not going to let that get in the way of my provision of services. Harm reduction, it really values empowerment, folks. We know that shame doesn't work. We can't shame someone out of addiction. And it's really about listening to people and taking away the paternalistic way that we've worked with folks, and that, I'm the expert. I know what's good for you. Well, we don't, we can talk about pharmacology and stuff like that, but it's really, it's up to that person and, to actually work with us. Right. And, again, it's coming from a place of caring. We have these degrees and we did this and we studied this. But it really is a shift away from that, and making sure we include folks who we're working with in any sort of treatment plans. Self-reflection, obviously, guys, that's something that we always have to do. I mean, don't be lying in bed at night, hashing through everything that went through the day. God knows I've done that. But it's about recognizing our own limitations, our own personal values, and how that can be reflected in our practice. I'm quickly going to go through this trauma piece, because I think that it's important that we can't talk about harm reduction. We don't talk about trauma, because the two are intricately connected. I only have 3 slides left, guys. So clinical studies have found that 80% of clients with substance use issues have experienced abuse. I suspect that number is much, much higher. It has been in my personal experience. I would say that number is more like 95 or even 99%. I've worked several years in treatment centers, and when I go through my clinical files, it's very hard to find someone, especially females, who haven't been sexually abused as children. That's not to say everyone who has substance use disorder has experienced that, but it's certainly, there is a correlation between the two, right? We know that male and female sexual abuse survivors experience a higher rate of alcohol and drug use, substance use disorders, and that people make the choices they do in an effort to manage that trauma. And that is, if you can remember one thing from what I'm saying here today, is understand that people are using to manage a trauma. And if you knew their stories, it would absolutely break your heart. So that's why it's important that we always act in a trauma-informed way. And that includes being trauma aware. So being aware of the prevalence of traumatic experiences with people who use substances, its impact on development and the relationship to physical health, mental health, and substance use. So we're not going to be trauma experts, guys. I have my master's in counseling. When I had someone with significant trauma, I would bridge the gap for them. Right? Like, I would validate, I would, crisis intervention, all this sort of stuff, but I would always refer them out to experts in trauma. Because one thing we don't want to do is we don't want to re-traumatize people, because that can be a very, very dangerous place for people, right? So being trauma-informed and harm reduction, they support each other in creating safety, control, and connection. And being trauma-informed involves, again, including patients in the treatment process, screening for trauma, training staff in trauma-specific treatments, and again, providing that emotional safety and engaging referral sources and partner organizations. And what I will say to you guys is that we don't have to know someone's had trauma to treat them in a trauma-informed way. I assume now everyone's had trauma. Everyone I meet in the day, I will treat in a trauma-informed way. People give me my coffee in the morning at Tim Hortons. Like, I always try to create safety, control, connection with folks that I meet. And I think that's a kind of universal precaution that we all should do in healthcare. So I'm almost done. So a lot of people think that, oh my God, if we open a safe injection site, or if we do this with an overdose prevention site, we're going to increase crime and public disorder and all that sort of stuff. And what studies show is it can actually lead to a decrease. And I compare this many times to back in the 90s when we started having condoms in high schools. I was in school in the 90s. I know I look really young, but I was a teen in the 90s. And I remember when they first started to put condoms in schools, and not everyone, but a whole lot of people freaked out. They're like, we cannot have condoms in school, because if we have condoms in school, then there's going to be sex everywhere. There's going to be sex in the gym and in the cars and in the classrooms and in the hallways and in the gym, all this sort of stuff. Well, what really happened when we look back is that the average age of people engaging in sexual activity did not increase, but what did decrease was teen pregnancy and STDs and STBBIs, right? So similarly, I feel it's the same way, right? People think that if we are going to have naloxone, or we're going to have needles, and we're going to have all that stuff around, then people are going to be more apt to use. Well, I can tell you right now, I have naloxone kits all over my house. I have syringes, I have safe supplies, I have teens in my house. My house is like Grand Central Station. I am not worried about that for my children. It's not a concern I have. I think that that's not true. A lot of people think that harm reduction is anti-abstinence, and I cannot say how untrue that is. I'm so happy when a client comes up to me. They're like, look, Jane, it's been like 5 years, 2 days, 5 minutes or whatever on their sobriety clock. Like, it's wonderful and it's beautiful. And the goal of harm reduction is not to lead to abstinence-based recovery. The goal of harm reduction is to support the person in living healthier. But what I can say confidently to you guys is that many, many times I have seen harm reduction lead to recovery. Right? There's not a goal, but I've seen that happen, because once people start taking those little steps towards living healthier and they feel supported and they're getting, good support from us, it's a snowball effect, right? A lot of people think it enables and promotes drug use. Again, there's no evidence of that. A lot of people think harm reduction is ineffective. It has saved countless lives. One day I was coming out of Home Hardware and there was someone having an overdose. I just happened to have 100 kits in the back of my car. Revived that person. We've had young people, 15-year-olds, who have had overdoses and they have been revived by naloxone kits. So people who say that, they're ill-informed. A lot of people say it takes resources for treatment. It doesn't. It only takes about 2 to 3% of all the monies that we devote to substance use disorder. So what can we do? We must be aware of our personal assumptions, values, and biases. For me, I had to get out of my own way. I used to think, oh my God, I would never do that. Like, what is wrong here? Like, why are these people drinking? Why are they smoking? Why are they doing all this all the time? And once you have a deeper understanding of substance use, we can figure that out, right? What are my professional obligations? We always have a duty of care, right? And if we can't meet those person's needs due to our own biases or our own judgment or whatever, then we have to find someone who can. What are the knowledge and skills I need to support this person? If I don't have them, I got to find someone who can. Be aware of body language and voice, and Wayne's going to get into this a little more. Make sure we're person-centered and show kindness, which I'm not worried about with this current audience because we are all in caring professions. That is it for me. I hope I just didn't sound like an auctioneer, but that's it.
Thank you so much, Jane, for all of this information, and I love the use of your examples. It was excellent. So I would now like to pass it over to Wayne to continue with our presentation.
Great, thanks so much. And Jane touched on a couple of the topics that I'll be discussing today. But thanks to all of you online. And I'm guessing that I'm speaking to an audience who could probably provide this presentation. So I'll run down through a few specific pieces of information, and this part of this presentation is really one of the pillars of harm reduction, and really that is really looking at stigma as it relates to substance use, and looking at how we use language and how we support individuals who use drugs in our healthcare system. So I will ask, I guess, some folks some questions before we start. And really, these are just questions for your own self-reflection. So when you think about substance use, what words or phrases come to your mind? And are they appropriate phrases that you would use in your current daily work? How do you feel when you hear the words like addict or junkie compared to terms like a person with substance use disorder? How does language we use shape public attitudes and policies around substance use? And can you give an example where a change in the language you used helped reduce stigma? So these are some questions to think about, and clearly we've got a long road ahead of us to really look at and address language and stigma in healthcare. There's a lot of critical work going on in this space right now, but there's certainly a lot more to do. So in terms of what we're going to talk about, we'll review the importance of appropriate language, when we're working with people who use substances. And then we'll also look very briefly at some outdated and more stigmatizing language. We're not going to get into this too much because there's lots of documents online that really identify specific terminology. So just, as Jane kind of paraphrased earlier, it's helpful to kind of have an understanding of the snapshot of substance use in Canada, and who does substance use affect. So theoretically, and these are some bullet points from the Canadian Centre on Substance Use and Addiction. So 1 in 10 Canadians experience substance use problems daily. 8 out of 10 Canadians with a substance use disorder may or have said that they experience barriers to recovery, including stigma. And almost half of Canadians in recovery from a substance use disorder experience stigma when in active addiction. So these are all very, very important, pieces of information. And we need to recognize that stigma is a major barrier to addressing addiction and substance use disorders and overdose in our communities. And it's interesting when we think about the word and the term stigma, which originates from a Latin and Greek term where it was used to mark an individual with a burn or a tattoo, and really used to signify a disgrace. So today, when we think about stigma, it refers to labeling, stereotyping, and discrimination. And it can take, shape in many different forms. Today, what we're going to talk about is judgmental language to describe addiction and individuals with substance use disorders or who use drugs. And what we know about stigma is that there's been significant research and extensive research done in terms of how stigma is widespread and persistent in healthcare, and really rooted in a misconception that addiction and substance use disorders are personal choice rather than a medical condition. So we have to recognize that stigma remains very prevalent, both in the general public, but also in healthcare. And professionals that regularly interact with individuals with substance use disorders, including, healthcare, people working in healthcare. And what we know specifically from both the pyramid of research, so including people with lived and living experience, is that stigma negatively impacts health outcomes. It reduces access to quality care and services, and certainly contributes to the ongoing overdose crisis, as Shane discussed earlier in the first presentation. So what we can do as healthcare providers is think about our own bias, our own experience, think about the terminology and the language that we use in everyday interactions with people who use substances, as well as our own colleagues. So as an organization such as NL Health Services, we need to address stigma at all levels of healthcare. And that's essential as we aim to reduce drug-related harms and improve support and services for people with substance use disorder, people who use drugs. Just jumping between slides here. Okay, here we go. So when we talk about stigma and how it applies to substance use, we need to be very critical. And in this part of the presentation, we'll talk specifically about types of stigma and the role of bias in healthcare settings. And ultimately, I would love to say that bias is a thing of the past, but bias is very prevalent all the time. And bias in healthcare is shaped by our own views, our own experiences, and the way that we've provided services in the past. So when we think about, advancing inaccurate narratives and reinforcing harmful stereotypes, these can have very, very significant and very, very serious consequences on people who use substances, even unintentionally. And this happens a lot, specifically in healthcare environments where people aren't always intentional with their use of language, but even unintentionally, many of us use language that perpetuates stigma and bias, and words that shame and devalue individuals and really discourage individuals from seeking support and help. The good news is that I think we as healthcare professionals can make small and very intentional changes in how we communicate. And ultimately, that will help reduce stigma and foster a more supportive environment. So I mentioned earlier, stigmatizing language and attitudes shape the way we provide services, but they also shape societal perceptions of individuals and their experiences. So we have to be critical and we have to be intentional and understand that substance use disorders are a medical condition and not a moral failing, and we need to shift our language to reflect that. For many individuals, and again, depends on your experience, your education, your beliefs, stigma can be very deeply internalized. And for individuals who use substances, this can lead to significant feelings of shame and self-doubt and increased feelings of isolation. So when people face judgment from healthcare providers, these feelings can certainly be more intensified. making it even more difficult for individuals to seek out help. So we know the World Health Organization, as many of you know and are aware of, identifies substance use disorders as the most stigmatized health conditions in the world. So stigma is reinforced not just through the use of words, but also through our behaviors, our attitudes, and our unconscious biases, which we need to reflect on constantly. So how does it show up? How does stigma show up? Again, we may unintentionally amplify stigma in our daily interactions and our use of terminology. So stigmatizing language and attitudes can really sound like defining a person by their substance use rather than looking at them as a person and a whole individual. We can dismiss their value based on their struggles with substance use. We can use labels that dehumanize and reduce a person to just their substance use disorder. And we can, shame individuals, and that certainly prevents, again, people from coming forward and seeking services and being provided the support and help that they need. I guess the biggest piece, again, would be for individuals experiencing stigmatizing language and stigma in general is really feeling invisible, unheard, and ultimately, and we hear this consistently, uncared for. So we talk about types of stigma. We think about self-stigma. So, theoretically, society has proposed and has this bias around people who use substances and people with substance use disorders as a very negative approach and very negative connotation. So when individuals internalize those in negative messages about substance use, they apply them to themselves. So a person sometimes, with a substance use issue or substance use disorder or using substance may feel ashamed and unworthy of help because they may feel that maybe their substance use is a moral failing or a personal failure. We also think about social and again, social stigma. And again, these negative attitudes and behaviors directed at people who use substances are alive and well. And sometimes that's from individuals, families and friends. So again, family members and friends may distance themselves from a loved one with a substance use disorder. And sometimes due to being fear of being judged themselves by other friends and family members. Structural stigma, which is one we do see in healthcare and one that we've got a long way to go on, really looks at policies and our systems level approach within healthcare and really social services that create barriers and really reinforce discrimination and stigma. So we think about policies that require abstinence from all substances, including prescribed prescriptions and medications like methadone or Suboxone as a condition for housing and employment. So again, we've got some work to do there. And the other piece to this, and there are other categories of stigma, but the fourth and final I'll talk about today is provider stigma. We need to be very critical as healthcare providers when it comes to our beliefs and our perceptions. So healthcare practitioner stigma, really happens when healthcare professionals have stereotypes that get in the way of their ability to providing effective care. So, for example, we hear this often, that an individual visits an ER service, and for different reasons, the healthcare provider assumes that, that particular patient at that particular time, the pain that person is experiencing may be what is referred to as a drug-seeking behavior and not necessarily seen as a legitimate medical concern. So how does this affect patient care? It certainly does. And certainly, that particular person, that patient may have decreased engagement with their healthcare provider. They may have increased emergency room visits as opposed to, really having their needs met in a primary healthcare environment. We may see increased rates of discrimination, neglect, and mistreatment, and certainly increased risk of harm, overdose, and isolation, as I mentioned earlier. So words matter. There are a number of resources that I'll tag at the end of this presentation, and I think folks who are online today will get copies of these presentations, so you'll see and be able to double click on some of these resources specifically. So when we think about words matter, it's certainly important to think about how we use people first language. So we think about using person first language to let individuals choose how they are prescribed. So sometimes I've worked and heard from some of our staff who work in addiction services that they will ask an individual, what language do you want me to use? What's appropriate for you? And sometimes those questions can certainly help an individual understand that the person is there to provide appropriate care and want to better understand that individual's recommendations. So words do matter, and the words that we use certainly reveal our values and our priorities and our perspectives. So as I said before, language is extremely powerful and carries very significant weight. So because this is really important as well, and I should have mentioned this from the top, is that the use of appropriate language is critical, because most often healthcare providers can be a first point of contact with someone with a substance use disorder. And for that reason, health professionals need to take the appropriate steps and reflect on, appropriate language and the use of appropriate language to certainly reduce any potential stigma and negative bias. So when we think about, the use of first person language, we think about instead of those very negative words like addict, we think about using the appropriate words of person with a substance use disorder. We think about a drug user or a user, and we use more respectful language like people who use substances. We think about those negative terms, and that foundationally negative term about substance abuse. And we need to really reframe that and refrain from using that term and think about more respectful terminology, like people struggling with their substance use and people with substance use disorders. We think about, individuals in healthcare that may be seen as injectors, and we need to think about more appropriate terminology, and including people who inject drugs. So those are some examples, and there are a number of resources out there that identify, very specific and specific terms that can be used. Again, using empowering and strength-based language is extremely important. And we, again, need to be critical about avoiding jargon and slang and using very inclusive language. My time is ticking down, so I'm going to try to skip ahead really quickly. I just wanted to share this because we think about just our use of language sometimes when we're interacting from a verbal perspective, but our language through documentation can also have critical effects. So this was one particular study out of the International Journal on Drug Policy. This was a randomized control study among mental health professionals, and certainly highlighted the power of language. So in this particular study, there was 314 individuals responded to 35 questions. This study demonstrated how words we choose can and do influence attitudes and reinforce stigma. So ultimately, this particular study gave two descriptors. So individuals were either described as substance abusers, while others were identified and described as having a substance use disorder. And what this one particular study identified is that participants felt overall that when an individual was identified as a substance abuser, it was less likely a person to benefit from treatment, more likely to benefit from, most likely, to see service from a punishment perspective, more likely to be socially threatening, and more likely to be blamed for their substance use related to difficulties, versus identifying that it was a healthcare issue in general. Great. So in terms of addressing stigma in healthcare, and I'm going to round out now very quickly, super important for healthcare professionals to reflect on their own personal biases and their own use of language. As Jane mentioned earlier, in terms of some of our pillars of harm reduction, self-reflection is critical. And we have to do that often. Using motivational interviewing and trauma-informed, equity-oriented interventions like trauma-informed care are critical, and creating non-judgmental spaces and implementing stigma-free policies. The other important piece of this, as we think about harm reduction, is education, and examples like today are critical in how we provide education to our workforce and scale up education and the use of appropriate language in healthcare settings. So finishing up and closing out, words certainly do matter. We sometimes use stigmatizing language, and we need to, certainly consider where that language came from. We need to encourage and reflect on appropriate language. We need to examine the impact of language and the use and the specific meanings behind words. And ultimately, and I'll just leave you with this, that individuals have the right to choose how they refer to themselves. And as professionals, we need to respect those preferences. And sometimes it's not always, we might not always adopt the same language in our practices, but we need to, as healthcare professionals, certainly reflect on our use of language. Our role is to build build supportive spaces and hold ourselves and our colleagues ultimately accountable for the language we use, and how language shapes attitudes and certainly reflects on access to care and overall well-being and health. So there's again, I'm seeing push to audience. I've got some references listed for people who want to take a deeper dive and double click in this particular area. There's a number of really, really great resources out there specific to healthcare providers, and these will be included when the slides are presented and provided to folks online. So with that in mind, I'm going to stop right now and pass it over to our next presenter.
Thank you so much, Wayne, for the information that you've shared. Certainly a great reflection for healthcare providers. So I'm going to now pass it over to Tammy Coffey-Hickey to continue with our presentation.
Thanks so much. It was great to hear Shane, Jane, and Wayne's account of harm reduction and certainly the work that's been done. I think one of the biggest challenges that we're seeing right now is harm reduction in acute care setting. So I have reviewed understanding from what's been established in a community-based setting. I have focused predominantly on a hospital-based setting. And sorry, I think I pushed the audience instead of next. Apologies. So my focus will be on harm reduction in a hospital-based setting. So I'm going to look at what's currently happening, what has happened in harm reduction, what is currently happening, and where we need to go. Certainly looking at the perspectives and experiences from the person or the patient who has used substances while they're in hospital or prior to coming into the hospital setting, as well as the healthcare provider's perspective and experiences. I've done a review of the literature focused predominantly on Canadian literature, and it is well established in a community setting. What we're seeing is an evolution, I guess probably since the around 2015, 2018, a lot of work has started to be done in Canada around harm reduction in acute care setting. So I'm going to provide some overview on some of the principles and then just to kind of bring it together where we are and where we need to go. I think the first thing we need to think about is traditionally from a hospital-based setting, we looked at our traditional model was a medical model, and we think about substance use or addiction as what some of the literature often refer to it, is that it labeled as addiction as any illicit substance used as abuse, as well as the moral model, as Wayne has referenced as well, which labeled drug use as wrong and therefore illegal. And it was traditionally thought around fixing the patient's behavior. We know that harm reduction, we need to shift to an approach that looks at emphasizing support to the patients who make harmful choices by meeting them where they are at, rather than focus solely on abstinence. So we need to reduce the risk of negative health outcomes. And when we think about it, a lot of our patients, as Wayne has referenced as well, the first point of contact with the healthcare system may be in an acute care environment. Many do not have primary healthcare providers. And they often come into our facilities with very complex medical health concerns that may have been ongoing for a period of time. So we need to certainly focus on helping the patients to address those immediate health needs, and then putting supports in place to look at how we can support them with their substance use. Patients, One of the things that when I'm looking at the literature around harm reduction in a hospital setting, there was a lot of discussion around from a regulated healthcare provider's perspective. So being a nurse, I certainly focus on, from a practice perspective, looking what is the nursing literature. I've done a review across Canada at a lot of regulatory bodies, and we don't see a lot of statements around, obvious statements around harm reduction. There were a couple at Registered Nurses Association of Alberta. There was another one with the College of Nurses of Ontario. But I think what we need to focus on, we may not get a black and white document that answers all of our questions. If we meet our regulatory requirements, we look at our standards of practice, we look at our knowledge, our skills, our expertise, and we then apply that. I think we can certainly meet the needs of, from a harm reduction perspective, for the patients, residents that we care for in our facilities. And one statement that I found was really interesting was made by the College of Registered Nurses of Alberta, and they referenced the Code of Ethics for Registered Nurses. And if we think about it, if we are able to meet our codes of ethics, harm reduction approach aligns with the registrant's responsibility to use inquiry, evidence-based knowledge to protect and promote a client's right to autonomy, respect, and dignity. And I think Wayne and Jane have certainly referenced that. We need to be aware of our own internal biases and our stigmas that we unintentionally or intentionally at times apply to our patients that we're serving. We need to be aware how we can meet the patient where they are, and then foster the principles of harm reduction. So in review of the literature, I think some of this has already been discussed, but just to kind of go through to provide just a comprehensive perspective. We looked at the patient's perspective or experiences while in a hospital setting, and predominantly this was based on Canadian literature. Wayne certainly gave a very good overview around the discrimination and the stigma, so I'm certainly not going to delve into that. But pain control is a massive thing that patients who have used substances certainly encounter while they're in our facilities in acute care. For a number of reasons. For some people may not understand because a patient is maybe using opioid or another, sorry, I'm not sure what's happened there, may have used opioid or another substance that they're using. People may not understand that that is not going to meet the client's or the patient's need for pain control, certainly in an acute care setting if they've had a recent intervention like an operative procedure or have an injury that's causing significant acute pain. So I think that's something that we certainly see, as well as there's also a concern that by administering pain control to a patient that we may cause undue harm to that patient as well. So it's certainly noted by the patient's perspective. Also, patients who have a history or currently use substance in our acute care facilities also experience cravings or withdrawals. They have a perception of lower quality care compared to those clients who do not use substances. They've often have negative interactions with healthcare providers, and that is at all levels, not just nursing, but certainly at all regulated healthcare provider levels with prescribers, with various members of the allied health team, as well as their experiences that they've seen with surveillance and monitoring that has certainly taken place, leaving them often with a feeling of powerlessness or loss of control over how to navigate their health journey while they're in their acute care facilities. As I've alluded to, they've also may have seen an increased monitoring and level of surveillance. Currently in our healthcare facilities or in our hospitals, currently from Newfoundland and Labrador Health Services, Eastern Urban and Rural Zones, as well as many of the other regional zones, we have a policy in place that all of our patients, residents, and clients are seen at a minimum of every hour. So some of our clients may have the perception that they have an increased level of monitoring. So it's communication is key. As we've referenced, there's a lot of work that needs to be done in terms of our policies, and I'll certainly allude to that a little bit more. But I think if we explain to our patients that we see all of our patients at a minimum of every hour, and that's to make sure our patients come with complex health crises. So we have to make sure that they're safe, we're meeting their needs, and we're able to assess and intervene as appropriate for our patients to make sure that all of their healthcare needs are being met. Many patients who have a history of substance use certainly report being restricted from going outside. Again, It causes significant challenges for these individuals, as well as for healthcare providers who have the perception that they may be able to restrict an individual from going outside. Oftentimes, they report visitor restriction for fear of somebody bringing a substance into our facilities. Patients also report that if they possess a non-prescribed substance that they may be using while they're in our healthcare facility, that they may be have an unwarranted or have experienced security conducting room searches. So there's a fear that their substance may be taken away from them, and that causes a whole host of other problems, as well as trying to conceal it, hide it, or secure it. They have it to be able to meet their needs while they're in our hospital. Clients also report experiencing verbal abuse or physical violence, whether it's from other patients, visitors, or various members of the staff in the hospital setting. And this part I found a little bit concerning when I actually reviewed the literature on this, but certainly it is accounts of being denied entry or forcibly removed from our healthcare spaces by security. So it's again being able to have access to healthcare that is needed, regardless of the reason that brought somebody to our facilities, I think is really important. But certainly we can see from their accounts, their experiences, and some of the problems that has led to for these patients. So we look at it from a healthcare provider's perspective as well, when reviewing the literature around this. Many healthcare providers not having the understanding of what it means for the individual with substance use disorder while they're admitted to our healthcare facilities. So the healthcare providers often report feeling hesitant, untrained, and unsupported in providing care for these individuals, making sure that they have the knowledge of what their disease means that has brought them into the hospital, whether it's acute condition or it's an exacerbation of an ongoing disease, and then compound it with their substance use disorder. And if one intervention, what it means then for the patient who's also concurrently using other substances that may or may not be known. Healthcare providers at all levels, whether it be registered nurses, social workers, prescribers, they also have a fear of liability. What does it mean for me as a healthcare provider without having the knowledge, the understanding what substance the person is using while they're in our facilities, as well as what is prescribed for that individual? So again, it's that understanding of the disease process for substance use disorder, as well as the treatments that's required for the patient's current condition. And they also have a concern not only about their own personal liability from a regulated perspective or from a legal perspective, but a concern for that individual's patient safety, having that comprehensive understanding of the challenges that individual is facing, as well as how they're going to respond to the prescribed treatment that's been ordered for them. And as well as personal risk. A lot of literature certainly references that, whether it's from incidental or inadvertent needle stick or occupational health exposure, from a physical, if behaviors have become escalated, reactive behaviors, and it's the de-escalation. And oftentimes that's a result of an anticipation bias. So healthcare providers report right, wrong, as Wayne has mentioned previously, people have different experiences while they're in our facilities. People have had previous experiences where it's become, to use Jane's words, sometimes the events and maybe a little bit chaotic around the person who's coming in with a substance use disorder if they're not, if they feel threatened or unable to continue to use their substance while they're in our facilities, as well as healthcare providers trying to navigate the process that is put in place based on current policies and processes within an organization, can often result in less than desirable interactions for the patient as well as for healthcare providers. And so based on that, we may have an unintentional anticipation bias as well that we see, leading to sometimes a mutual mistrust between healthcare providers and patients who use substances, whether it's because the person has not disclosed or is somebody not being aware of their own personal bias as well. There's a fear of deception and lack of training as barriers to establishing therapeutic alliance. I think we clearly see that there's a lot of work being done around harm reduction, education for healthcare providers. There's fabulous programs that have been established, as well as a harm reduction team as a community-based. But what we're seeing in the last 10 years is more of an evolution to an acute care setting. So we have a long way to go, but we still have a lot of knowledge gaps and understanding what needs to take place. Healthcare providers also report feeling very in a difficult position to have and surveil patients. So again, sometimes it's resulting back to policies and practices in our healthcare facilities, not necessarily based on the individual needs or the higher level of surveillance based on the patient's condition. Oftentimes as well, there's an inconsistency in approach. Not every healthcare provider has the same understanding of harm reduction in our acute care facilities in the absence of an organizational direction or policies. So we often have inconsistencies, and this leads to more challenges and struggles as well. If you have different shifts, different teams approaching things differently, and it causes, a concern and a fear for the individual patient who use substances as well as for the staff. So it can certainly be very challenging. There's also a moral distress when you look at the literature as well for individual healthcare providers who often feel that they're forced to mandate addiction treatment to patients who may not be ready, or to force an abstinence while they're in our care. So that moral distress is certainly very evident in our healthcare settings. So what does this really mean from a hospital perspective? We see some of our patients who use substances try to hide their injection for fear of being penalized, and that results in more higher risk practices. We have people that are injecting in a rushed setting, either injecting alone or in unclean or shared spaces. Certainly washrooms, if you think about a public washroom, it certainly increases a lot of risk for people who use substances if they have to find themselves at certainly safe space to inject because they can lock the door behind them. They may not have clean or sterile supplies, so they may be trying to conserve the supplies they have and trying to secure them in an unsafe place. And that can certainly lead to infections or overdoses as well. And when you actually look at the literature for people who have vascular access devices, whether it be peripheral vascular access or central venous access devices, for oftentimes patients who use substances, if they feel rushed, will often use their vascular access device. It's quick access, and they can often use that without having to fear of being certainly walking in on them or trying to navigate their other routes where they would certainly consume their substance. They often we see a reluctance to access services, even if they are offered in our acute care settings, or disclose their substance use for fear of shame and discrimination, and not the perception of not receiving the same level of care. So again, that in itself causes a lot of challenges for both the healthcare provider as well as for our patients. And as I've already referenced, they've had some patients have negative experiences with the healthcare systems, and that may influence when they will seek out medical care in the future. When will they come back to our emergency departments or outpatient clinics and become a patient in our healthcare settings? And that may be certainly a missed or cause a delay in care, delay in treatment, which can result in increased severity of their acute need, or an exacerbation of a chronic health condition, and a missed opportunity for earlier intervention. So it certainly causes a lot of concern. As others have already mentioned, we have an increased rate of self-discharge. Actually, some of the literature references up anywhere from 25 to 30% higher for patients who use substances as compared to the general population may actually discharge themselves against medical advice. And based on that, then as well, we also have the complications of, again, failure to intervene, failure for follow-up, and the other complex health concerns that can arise as a result of that, often resulting in higher readmission rates, increased mortality compared to patients who have planned discharges. And as well, because of the negative experience people who use substances may encounter in our hospitals, it may also result in decreased retention in treatment programs. So when looking at, sorry, I think my slides were, can you see the next slide? I was having trouble.
Yes, Tammy, we see harm reduction principles for inpatient healthcare settings.
Sorry, I'm not sure what was going on with my slides. You can try this as many times as you want. There's always going to be something happen, so my apologies. So when I look for harm reduction principles for inpatient healthcare settings, I think that, as I've said, we are seeing processes and programs well established based on a community perspective. What we're seeing in our healthcare facilities, the calls we receive from various healthcare providers, whether it be nurses or social workers or other members, regulated healthcare providers, we're seeing a lot of challenges that people are facing. So when you actually review, we have a long way to go. I'm not going to pretend that we don't, but when you actually review, there's a lot of some themes, common themes. So when I looked at this, actually, I found 6 common themes or 6 common principles for inpatient healthcare settings that would certainly facilitate a much more broadened or philosophical approach to harm reduction in acute care. So I'm just going to walk through these a little as we go through. And as Wayne has mentioned, certainly education is key, certainly from a destigmatizing language or approach to healthcare. Sessions like today, we certainly see the value and the benefit of raising people's awareness to some, while we may have a basic understanding of harm reduction principles or philosophies, I think it's this deeper level that will certainly raise people's awareness and cause us to reflect a little bit more on some of the language we use, whether it's verbal language and sometimes our body language we use as well, avoiding eye contact, not embracing and engaging with the person who uses substances, avoiding eye contact, looking at the floor. I think we also need to be very much aware of that as well. We see currently in our healthcare environment, we often see harm reduction education targeted to pockets or groups of regulated healthcare providers. So we certainly, from a nursing perspective, I certainly am aware that it's incorporated into the practical nursing program as well as the baccalaureate nursing program. Harm reduction is threaded throughout their basic education programs. As we see a higher call for harm reduction in acute care, which is certainly a great thing, we're seeing more requests for harm reduction in our healthcare facilities, education on that. But sometimes what we often see is the education, and this is not meant as a negative or as a punitive, but I think it's a reality of what we see based on where the request is coming from. It may be just targeted to one group of healthcare providers, whether it be nurses, social workers, or other groups. And it's often targeted for that reason because they have dedicated education days or dedicated education times, or a result of a situation that occurred on a particular inpatient unit. What we really need to see, and some of the areas that have been very successful in incorporating harm reduction as part of the philosophy or approaches to care in a phased-in approach, is to have that harm reduction education open to all healthcare providers, whether it be nurses, social workers, pharmacists, allied health professionals, as well as the prescribers or physician groups as well. And I think that would certainly be a great benefit and a way to move forward as well, where people having the opportunity to have in this higher level of understanding of harm reduction incorporation and what it means to our practice on a day-to-day basis. Some other areas of certainly, and Shane has mentioned this, what substances are we currently seeing in our communities? Because if it's in our communities for the populations we see, we could expect to see comparable substances in our healthcare settings and certainly in our hospitals. So in some areas, in some situations, they've brought in whether it be police or different harm reduction organizations into our facilities to actually demonstrate what the substances are, or to speak about the volume of the substances, what they look like, how are they ingested, so we have a greater understanding. As a nurse, when I'm providing care for a patient who has a substance use disorder and they may be using, which high probability will continue to use, whether they disclose or not to us while we're providing care, it's very important that we understand what kind of assessment we need to do, what we understand when we're providing other interventions and therapies, that we have that knowledge base so we can provide safe care to our patients. Another thing that we need to think about, as Wayne and Jane have certainly mentioned, our own internal biases, whether intentional or unintentional. And we have to be aware individuals have the right to, whether it's, they have the capacity to inform decision-making. So many centers bring in ethics to have those conversations around the person's right to choose, whether it's living at risk or continue to use their substance while they're in our facilities. We've made great strides around opioid antagonist therapy for those individuals that are interested in availing of opioid antagonist therapy or may have been started in our community-based settings over the last 10, 12 years. Certainly we have processes and policies to help guide the continuation of those therapies, as well for an individual if they feel they're at a situation or point in their journey that they want to avail of those therapies while they're in our healthcare facilities, then they have that ability now to reach out to the resources around them, to notify their member of their healthcare team, and start those conversations around the initiation of opioid antagonist therapy. It's not for everyone, but for those that are choosing and are at that point in their journey, we certainly have that available, which is a very good positive thing that we're experiencing. As I've mentioned, many patients around managing acute pain, and that understanding when we have our opioid naive or our non-opioid naive patients we're providing care to, whether or not they have a substance use disorder, is understanding that acute pain and the need to treat that pain. As already previously mentioned, many patients choose, or are you not choose, I shouldn't say that, I apologize, but are using substance for a variety of reasons. It may be past traumas, or it may be, other things that led to or continuing to use that substance, as Jane mentioned with the person who referenced that the substance kept them alive. We need to be aware that we have to certainly meet all of our patients' needs and not just have an assumption or a bias, because they may have disclosed that they're using opioids separate from what is prescribed, or if we have a high rate of suspicion, we still need to make sure that patients' pain control is met. Because otherwise, the patient is not going to stay engaged, they're not going to stay in our facility and receive that care that they need to take care of their health problem that has brought us to our facility. I think for some of us as well, and I say I'm a registered nurse, as you're aware, I think we may have an assumption that we understand some of the complications of substance use, whether or not it's a drug use or a non-prescribed substance, but I don't think we all have that true understanding, and the environment, the community, the substance that are being used, as Shane mentioned with his data that he presented, we're seeing a shift all the time. So I think it's that we have that education around the complications and the use. Information targeted prescribers as well. There's often a fear from prescribers that has been very well highlighted in the literature around the fear of causing harm to patients who use substances if they prescribe the wrong substance or therapy for the patient, as well as the concern from a liability perspective. Safe supplies, I'll talk about it a little bit more as I go forward, but certainly that need for safe supplies to reduce the risk for our patients that are in our facilities. And we get questions all the time from frontline nurses around vascular access devices. We have a patient who has either a peripheral or central venous access device, and how do we manage that care for that device and provide therapy through that if the patient has disclosed they used it, or if there's a high rate of suspicion. So we certainly help guide and navigate that as well. We have a lot of supports in our facilities that staff may not necessarily know about for de-escalation strategies and hospital resources. And again, how do we engage and certainly incorporate these patients who use substances into their care in a respectful and therapeutic manner as well. And then the linkages for community support. So there's lots of education. These are just some examples that we kind of talk about. I think one of the other things when the literature looks around is our harm reduction policies. And I think the first thing we need support and direction from our hospital leadership, enable leaders to address administrative barriers to timely manner to intervene. So we certainly advocate. I'm on some committees with others groups that are here presenting here today. And I think that is one of the biggest things that we need to understand. What is our organizational direction, and how do we incorporate harm reduction principles and philosophies into our approach to provide care without causing unnecessary barriers to our patients? Oftentimes, policies that we have that are intended to ensure patient and staff safety may be causing discrimination and maybe increasing the stigma, as Wayne referenced. So we need to be cognizant of that and certainly reflect on those as well. And part of doing that, I think once we have our hospital leadership direction and support, we have the need certainly well been identified, the need for a multidisciplinary team involvement in developing those policies and directions and practices. We have some pockets of it happening, but I think we need a broader view and a broader perspective, as well as involving the person who has a lived experience of substance use. There is no better person to speak to what their needs are than the person who has lived it and experienced it. So I think if we have that as well, it's certainly be a positive step moving forward. And as well, a lot of the literature talks about the role of all members of the multidisciplinary team. And I'd be remiss if I also didn't involve protection services or security. There's a lot of literature around the person's experience with substance use in a hospital setting and involvement of protection services and security. Not all negative or punitive, I just want to clarify that. But I think sometimes we need to be cognizant some individuals with substance use may have had some trauma in their past, may have had some interactions with the law as they've gone through their journey of substance use. Not everyone, but some certainly may. So we need to be aware of what that uniform presence may look like and what that may trigger or cause an alarm for the person who's in our facilities. So I think we incorporate everyone into our decision making and certainly have those open conversations in a safe dialogue. It certainly would be beneficial to our healthcare providers as well as to our patients that we service. The next area as well that when we look at it is around some of the themes in the literature was the incorporation of an inpatient addiction consultation services. So we certainly have that in pockets, but I think what I'm referencing here is much more formalized and structured approach around consultation services and the value that they offer. It's measurable actually when you look at it. They can certainly, they're the clinical experts as well around the addiction services and the how to manage someone's acute pain, the therapies that can be offered, or the interventions, the supports, the navigation of the system for patients who use substances, as well as provide that clinical expertise to our healthcare providers. So they can certainly assist with timely referral with the initiation of opioid antagonist therapy. If the patient is at that point in their journey and they're seeking it out, we can certainly avail of that service. They can prevent patients with high tolerance for opioids from being undertreated for pain. So that consultation, so we have a better understanding of what their substance use they may be using, how then we treat that acute pain and the volume of opioids that person may need to treat their acute pain. Certainly would provide some prescribers who don't have that knowledge or experience, that consultation would be very beneficial. As well for the individual patient, they can provide consultation interventions to promote coping skills, adherence to medical intervention, and to certainly help recognize early withdrawal as well. Provide, as I've already referenced, education to our colleagues at all levels, whether it be prescribers, allied health disciplines, including social work, registered nurses, any member of the team, and as well for patient-specific education. And then that navigation or linkage to our community supports, that outpatient, which Taylor is going to mention as well. I think that's very vital. We keep that linkage and that network going as we move forward. So when we think about some of the other things that we need, we have very different practices happening around safe injection supplies in our healthcare facilities. We have very well-established processes that are community-based, as referenced with our harm reduction team, a very comprehensive team, access to safe supplies that could be bundled in various ways. But patients in our healthcare facilities, in our hospitals, may never have disclosed that they're continuing to use substance, may not have access to safe supplies, as I've referenced, that causes other problems. So we need to have a formalized approach to in-hospital supplies, including, and I'm certainly no expert on this, I'll leave this to the experts, but when I think about some of the supplies, certainly sterile needles, syringes, sterile water, or substances that can be used with their substance if the person is injecting, alcohol swabs, tourniquets, and whatever else the patient may require. And a process for handling and disposal of used supplies. So it's safe for the patient, but also safe for healthcare providers, so to prevent those inadvertent exposures or risks that happens. When a review of the literature, and like I said, I focus mainly on Canadian literature, there are some that I looked at from the US, and interesting enough, one study out of California referenced Alberta and the work that they've been doing around harm reduction, and that was the Royal Alexandra Hospital as well in 2018. But some areas, it could be a nurse-led exchange. Some facilities, they actually have bundles of supplies. They incorporate it into the patient's treatment plan. It may have been ordered or have a plan to when the patient will certainly, how the supplies can be made available to the patient. It may be somebody from addiction medicine consultation services that may help provide that linkage to access to safe supplies, or it could be in a central location for the patient to individually access. So then there is no shame in that person or fear for the patient of retribution or retaliation of any sort, whether it be intentional or unintentional, if their healthcare providers become aware that they're continuing to use of substances. And in other facilities, it's a peer exchange, and that seems to work very well as well. I think the key, though, is that we need to make sure that whatever services or supplies are available to the patient in the community, that we mirror that in our hospitals so that we have no disruption in what supplies are available to those patients as they continue on from an acute care to a community-based setting. One article I read, actually I found it very interesting, was that in one facility, in one study, that the staff just magically left the supplies by the patient's bedside when the patient was not aware. So they may have been out of the room for a period of time, or they may have been asleep. And while it was deemed to be very beneficial in some circumstance, for patients who are going through the journey of abstaining from their substances or going through a treatment program, they often found it very troubling to come back into the room and see the supplies there. So I think communication and have conversations with our patients and how supplies are available, or make them available in more than one medium or more than one domain. So then we don't force the same approach to every patient, because everyone's journey will certainly look a little bit differently. Another principle that's very well articulated in a couple of articles that I read and some of the research was supervised consumption spaces. We're not there yet. Here in Newfoundland and Labrador Health Services, the Royal Alexandra Hospital in Alberta was the first supervised consumption services that I was able to identify. And this was certainly, I think, in my understanding, it started the consumption site, or the area where the individual who's using their substance would go to a designated area of the hospital, would be able to use their substance, and knowing that there was a healthcare provider there who could intervene if there was concerns. They could provide continued ongoing education, great opportunity to distribute supplies, as well as do additional teaching around vein safety, other harm reduction principles, or education. What supports are available in the community when the individual leaves our facilities that they may or may not have knowledge of, but it's that connection and linkages. So it was viewed as a great opportunity as well to occur. It can also help alleviate some of the concerns around the primary assigned healthcare provider who has multiple patients, not just the person who's continuing to use substances while they're in our facilities. They may have as high as 4 or 6 other patients that they're trying to navigate and coordinate the care for these patients, and a concern that they may miss something or fail to intervene if somebody has a respiratory depression or has a concern if they're continuing to use their substance. So it provides that safety for the healthcare provider to know that the patient is having those accesses, or if they run into problems, that they can be immediately provided supports, and as well as the patients. They may be able to go there depending on how they're set up. There's not a lot of literature, actually. I've reviewed the Royal Alexandra's guiding documents of substance and acute care, as well as Winnipeg and other areas across Canada in different phases of rolling out different harm reduction strategies. Some are not quite there at supervised consumption spaces, some are, but how they're set up will look a little bit differently based on the facility, the resources and supports, and what is the organizational direction around those. So a lot of them reference that there needs to be ongoing evaluation of these programs. There can be standardized practices or principles around that. So it'll be very interesting to see how things unfold in the near future as this becomes available. But interesting enough, in reviewing one of the articles I reviewed, they conducted a large systemic review, and they noticed that there was, in these supervised consumption spaces, because naloxone was readily available, there was no fatality noted within the facility. So that's certainly very positive, and as I've said, the opportunity to provide that harm reduction to help navigate the person towards the safe supplies and provide education while they're in our facilities, which is a great benefit from them. However, like anything, there's always fears or concerns. So for some areas, it was well documented. Some patients, even though they may exist, some of our patients who continue substances in our acute care facilities don't always available, because you have to look at their past experiences. There's a real legitimate fears for patients as well around being stigmatized or being mistreated by other healthcare providers as well. And then we also need to be cognizant of, if we have patients that are moving through different units or different areas of our healthcare provider facilities, what does it mean for the handover and transfer of information? So we don't want to cause an increased burden and risk for the patient. We want it to be a safe space for patients to be able to go and continue to use their substances and know they're well cared for. But we also need to be aware of what will it mean based on our current policies and our processes for the healthcare provider as well. So there's a lot of work that needs to happen. I think we're going to see some, hopefully some positive growth in this in the future. We're not quite there yet, but I think the literature clearly explains the benefit of it. So when we look at the last thing that I think about, some of the principles of where we can go, is naloxone. So we are all aware that the provincial government a number of years ago had made naloxone distribution kits available to the public. So in many of our healthcare facilities, including our hospitals, they are available in different clinics, different departments, and emergency department right across the province. Naloxone kits can be available to the public. So any member of the public can certainly go request a kit, and they will provide it with the information, the kit, how to use it, as well as how to replace the kit, and other resources could certainly be provided to them as well. Some areas it's nicely packaged in a bundle, as Jane is fully aware of and certainly supports this. So that has been happening. We've also started a couple of years ago, we're seeing higher and higher calls in professional practice around requests to help nurses navigate providing care to patients who use substances in the absence of a standardized approach. So we have been involved. We are one person at the table, no different than Jane and others, and Wayne and others, members of the healthcare team, have been also at the same table to try and put processes in place to help support our regulated healthcare providers and support our patients who use our substances. So in one of our acute care facilities, we have a pilot currently happening where patients are provided with naloxone kits on discharge. And then members of the public can still access the kit in the same facility through the emergency department or the public kit. We're also in a process right now of looking at that provincially. So there is a group that are looking at that. We're looking at policy development and how that can be operationalized as well. And the other things we're looking at, we have naloxone medical directives. So for anyone who's not aware, a medical directive is a specific generalized order that a registered nurse can certainly use if the patient meets a certain criteria, and they can administer naloxone without a patient-specific order. So it's meant in urgent and emergent situations, because prior to the use of medical directives, we had to have a patient-specific order. So it's meant to prevent delays in care, delays in treatment. We're seeing several of our programs and practice domains where the teams, including the clinical chief or the authorized prescriber, have certainly been involved in the development of medical directive to our inpatients for the administration of naloxone if they meet the criteria for respiratory depression. And we also are seeing work being done on that on a provincial level as well. And interesting enough, when we started the pilot on one of our inpatient units, I have been navigating with the regulatory body, certainly with college registered nurses, college licensed practical nurses, because we became aware that naloxone had to be, the classification or the scheduling of naloxone in the province had to be revised so that nurses would be able to distribute naloxone kits on discharge. And so that became that change was made in March of 2024. So that was a very positive thing. So that went out in our college registered nurses practice notes. I apologize, Kelly, if I've labeled that incorrectly. So we're seeing a lot of work still being done, and there's a lot of work still to happen, but we're certainly making progress. So based on that, just to kind of bring it all together, where we are and where we need to go. Where we are continuing to advocate for an organizational direction on harm reduction incorporation into acute care, certainly to meet the needs of our patients who continue to use substances, as well as to provide safety for our healthcare providers, whether that's for personal safety or safety in their practice. And we constantly provide linkages with our regulatory body. Interestingly enough, some of the areas that have been very successful in incorporating harm reduction into the philosophy of care have also involved regulatory bodies coming into our organization to speak to the different regulated healthcare professionals. While we practice and certainly communicate that message, there is value of hearing it directly, and then for our regulated healthcare providers being able to speak directly based on the environment we're in, based on our policies, the expectations of what it means from a regulatory perspective. As I started off saying, that we are able to meet our standards of practice around harm reduction, but we certainly need to have an organized and a standardized approach. If we don't have those formalized policies, we have inconsistent practices, we have some informal policies happening. So we know where we need to go. We need to have that organizational direction, that leadership, have all of the parties and stakeholders at the table. Members of the multidisciplinary team are people with our lived experience of substance use, and to start the foundation to incorporate and to look at all of the policies to remove that stigmatizing language or the barriers that can provide safe care to our patients who use our substances. I think that's everything I have. I'm not sure if we'll certainly leave it. If there's any questions, I'll certainly be available, and I'll pass it over to Taylor.
Perfect. Thanks so much, Tammy. This is Wanda here. I'm just going to let you all know we were a little bit late starting, so we are going to run over a little bit past 4 p.m. today just because of the later time starting. So without further ado, I am going to pass it over to our last presenter, Taylor, to continue on with our presentation.
Hi, thanks everybody. For those of you who are still here, I'm going to try and run through my section as quickly as possible. Luckily, I can do that because a lot of the points are going to be, kind of repetitive. They've already been explained in depth, so we're just going to run through what I have here. And thank you for still being with us. So I'm a social worker. here in Newfoundland. My full-time permanent position is actually with the harm reduction team, which has been mentioned a couple times today. And my background is in addictions and through inpatient, ODT clinics, and through the outreach team now, which is the harm reduction team. And so I'm just going to talk to you a little bit about what drives harm reduction services and approaches, but I am going to talk a little bit about how it relates back to some social work principles as well, but it will translate across all professions. So we're going to talk about harm reduction principles and philosophy of care. I just want to note the trauma-informed care. Jane already did hit on this. Person-centered care, really building trusting relationships and the importance of that and how doing that can really help your approach with clients. We want to look at lower barrier services that consider all the social determinants of health. So when you think about healthcare in our communities, we need to consider all those things and our community partners. Allowing clients to set their own health priorities, meeting clients where they are, and being present and consistent with your approach to the work that you're doing in terms of like building trust with the clients that you're working with. So we're just going to chat a little bit about the social determinants of health. So when you are working in a healthcare system, we are very focused on, the basic things that you think about when you think about healthcare, but we need to be looking at the whole social determinants of health. So they are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, worship, and age. These conditions include a wide set of forces and systems that shape our daily life, such as economic policies, systems. They help develop agendas, social norms, social policies, and our political systems. So as social workers and as healthcare providers, if you're coming from a different profession, regardless if you're working in government, healthcare, or the community, we do need to consider the social determinants of health, what they look like for each individual, and how our system is impacting the individual in being able to attain those. One thing that, if you're working, say, in a hospital, because Tammy just talked a lot about hospitals, is thinking about collaboration with the client, but then also collaboration with the community, because it has a lot more to do with whether or not you got your vaccine or not. It's the food you're eating, it's education, it's your social connection. It's whether or not you have a roof over your head, right? So it's a whole lot more. And so when we think about a harm reduction approach, one thing that I try to do as a social worker who practices a harm reduction approach is to see the client very holistically. And in order to do that, we need to bring in the social determinants of health. So I'm just going to move on now to the harm reduction principles. These are kind of laid out here from a healthcare lens. This will be healthcare driven, but if you're coming from a community organization, you're going to see that these are very applicable to you as well. So as Jane already talked about, humanism. So we're going to accept the client's choices. The services, we want them to be user-friendly and responsive to client needs. And we really want them to be trauma-informed. This is also the stage where we're going to see that we really want to respect the patient's dignity and their worth as a person. And if we look at the social work principles, that is number one. So, for people who are really uncomfortable working in the gray, which is often where you find harm reduction approaches, you can always bring it back to the harm reduction principles and to your social principles or your nursing principles, because they really do align and support each other. So there's pragmatism. So we don't assume the client's goals. So for example, as somebody who's worked with a lot of substance users, we're not going to assume that when they walk through our door that they want abstinence, as other people have mentioned. Their goal might be that maybe they want to stop injecting. Maybe that's their goal. Maybe they have no interest in stopping using the substance, but they'd like to decrease their use, or they'd like to switch how they're using so that it's a little bit safer for them. So it can look like a whole pile of different things, but we need to recognize that there are no perfect health outcomes for anybody, really. Like, we'd love to achieve them, but it's not realistic. So we're going to look at how can we help improve this person's health outcomes for what their goals are. We're going to focus on what the actual harm to the client is, and not our societal standards, not our biases, not our opinions. So we're looking at like the actual physical harms and how can we help mitigate them that align with what the client is telling us that they want. So individualism. So we want to assess each client's strengths and their needs. We don't want to make assumptions based on select behaviors. We need to view individuals intersectionally. So people come in and they're on a spectrum of the harms that and the behaviors that they might be engaging in, and also a spectrum of what's going to work for them and their stage of readiness. So then we have autonomy. So they're the experts in their own lives. I feel like if you can get that in your head, that clients are the ones leading their own care in terms of telling you what they need, then it just, your relationship with them is going to be so much better. Everybody just wants to be heard. Everybody wants to be treated like they're human, and allowing them to have choice in systems where often people have told them, well, it's this or that, can be really, really helpful. Then we have incrementalism. So any positive change, any little step forward that we can get with them. So like I mentioned in my earlier example, if that means that now they're not injecting and maybe they're still using substances in a different way, but we've decreased the risk of, say, developing abscesses, then we're going to take that, because chances are they might come back to us then, the next time they want to make another little step and onward, right? And accountability without termination. So we want to have low barrier services, low barrier spaces, non-judgmental approaches, so that clients keep coming back. We're not going to tell them that we're not going to serve them just because their goals don't align with what ours do. And all of these things really do link back to our professional principles of practice in terms of promoting social justice, valuing the dignity and worth of people, and valuing our human relationships with people. So I don't have a whole pile of words on the slides. I figured this far into the presentation, you guys might want to look at something more colorful. So I did not in any way create these. These are pulled from other coalitions online, but it has a lot of really great messaging in it. And the one that I liked the most is, this is a whole lot of gray to work with. So as a social worker who's worked in this area, you have to be comfortable working in the gray. We have to get comfortable with individuals that are maybe making choices, or their circumstances have led them to be in a position where the choices that they have in front of them might not align with what we would consider socially acceptable or standard practices and all these things. So in a variety of settings, we're gonna have to think really creatively to help support this individual and honor their autonomy and their right to self-determination as an individual with capacity. And I cannot stress enough that just because somebody is under the substance does not mean they don't have capacity. And I think I've heard that sometimes from people is like, oh, well, they've used the substance or they don't have capacity. It's like, well, their tolerance may be pretty high for that substance, and they might know exactly what it is that they're doing in this moment, making these decisions for themselves, and we need to help support them in that. So we also want to be consistent in this work with clients to help form this connection. We want to build trust and a sense of emotional and physical safety. So we want our clients to feel seen and their voices to be heard, and that for them to know that when they come to you, that you're not going to judge them, you are going to believe them, you're going to work with them on what their goals are, and you're not going to try to tell them what's best. You're going to let them lead and kind of work with them. And I think that's really important. We see sometimes in the helping professions where people are doing for people, it comes from the best place in people's hearts. But one piece of the harm reduction approach is really building autonomy and encouraging clients to be the leaders in their care. So I would really encourage people to think about doing with instead of doing for, to help clients identify their goals and help them work towards them. It just helps with that trust and your relationship. And it also is going to help that client want to be more honest with you. So one thing that I think about it, I think Tammy mentioned, is the idea of, say, like a needle stick, if you're in the hospital. I've been in situations with clients where they have things on them that in that situation, maybe they've said to other people that they have it. And I've walked in the room after having that relationship with the client. having done all this and built that trust, and they'll say, hey, I have this on me. Or this is what's going on, and I told them I haven't been using, but actually I have been, and here's all the dirty supplies, and I don't know how to get rid of it safely because I'm afraid I'm going to get in trouble. But when you have that relationship, people are going to be more honest with you. You're going to get a fuller picture of the situation, and it's actually going to allow you to support the client more holistically and safer for you, for the client, and for the rest of the staff that are present. So in that, we really want to think about improving our own education around harm reduction tools and programs. So if you're not comfortable with the idea of harm reduction, I mean, it's a new topic for a lot of people. And so one thing that I would really encourage you to do is come to presentations like this, get more involved. Like, start looking at what programs are out there in your community, especially, for example, if you're working in a hospital setting and you're doing discharge planning. There might be some really great organizations that are going to be able to support that individual from a harm reduction lens, support their social determinants of health, and really be able to help support them so that they're not readmitted, for example. So in Newfoundland, we have several programs, and if you're elsewhere in Canada, those programs do exist locally there as well. And they range from a whole pile of things that we think about as harm reduction, like the naloxone program and safer drug use. But harm reduction is not a program, it's an approach. And so I want people to also think about what community organizations are out there that are using a harm reduction approach, because we have a lot here. We have a really excellent community of organizations that are doing this work, and it really shows when you speak to the clients that they say to us that they feel seen, and they trust these organizations and these the workers in these organizations. So, you know, if you're not sure, pick up the phone and call. People are really, really, really receptive to talking to you about supporting clients in our community. I can say that from experience. We also have a full interdisciplinary team here on our NLHS. There's a photo, a very old photo of us at the regatta a few years ago. And we do have, you know, full interdisciplinary complement, as Jane mentioned earlier in her presentation. We are mobile. We're also, you know, we also have a set home location, and we are very open to working with people and helping educate. So if you're not familiar with something, pick up the phone and call. We're more than happy to help you navigate any of the situations as we can, right? And I say that I've moved on from the team, but it's anybody who has harm reduction at their heart will certainly answer your questions. And more comfortable with the idea of harm reduction in terms of the tools and services and who to call when you have a question is only going to help you engage in this work more confidently. So we have our community resources, but you can also call your professional practice leads. You can call your colleges, you know, to bounce ideas off as you get comfortable working in the gray. And the more you do that, you'll find that you don't actually need to do it forever. It's an approach that you can learn, and the more you incorporate it in your day-to-day interactions, regardless of where you work, you are going to get more comfortable with it, and you're going to find that you're going to start seeing results. So I'm just going to move on here now to the impacts of the harm reduction work. So I'm happy because it came at a time in my life when I really needed it the most, and they were able to help me with most of my problems. I'm not completely okay, but I feel better. I feel like I belong. I feel happy. I feel content. That's not something that I've had in 5 or 6 years, and I'm more open and I'm more free. So that is a quote from a client. We've got others here as well. So the best part of it is the love, to show that you are being cared for. I'm not alone, because before I didn't have anywhere to go. I didn't have anybody to talk to, anybody to get advice from, but they've been everything, helped me with everything. And I think this just really speaks to the impact that, you know, when people are being stigmatized against and being told what to do and not being heard, not being believed, being pushed off because maybe they use substances, for example. It can be really, really hard for them to feel comfortable walking in somewhere to get care. So if you can be that one provider, that one person that can do that, even as our system is going to take a lot longer to change, but if you can adopt this approach, regardless of where you work, and start making it a safer place for people who are using substances or engaging in any behavior that is deemed risky, by our systems, right? So I trust the providers here. I have only one thing to say. I trust them, and that is the one thing that makes it very easy for me. I feel comfortable reaching out to them if I'm going through a rough time. And, you know, if you work in this field, you will definitely go through journeys with people. And it might be that one day it's them, you know, not wanting to inject over something else. Maybe they just want clean supplies. They want education on how to do it safely. A year later, you might be helping them reunite with their family, anything in between, right? There's a whole wide range of how this approach can be helpful. So these are just some examples to kind of hopefully hit it home for people. And then I know I'm kind of cluing us all up, so I just wanted to touch on some concluding thoughts and some points for a future rooted in harm reduction. So we want to reflect on our social work values or our nursing values and how they connect with the harm reduction principles of practice, and how you can use those to help guide decision making. If you're somebody who's not comfortable working in the gray and you really like to have something in black and white, it's never going to be black and white. Every situation is different, and it does require flexibility. However, you can go back to those principles, because if you look at them at the core, they're very similar. And as other people have already talked about, trauma-informed care, if you're somebody who feels like you don't have a background in that, there's lots of free training out there. There's lots of training that counts towards your continuing education credits. I really, really encourage it, because regardless of who you're working with, using a trauma-informed lens is only going to be helpful. The use of language, I can't thank you guys enough for talking about that earlier. That was beautiful. So really think about that. Interdisciplinary collaboration. So I have seen that firsthand from my small team that I worked with, but also collaborating with the hospitals and other programs in different areas through mental health, through primary care, like having that collaboration in community with community organizations is really, really, really important. In my role, was collaborating with community organizations almost daily, and it made such a huge impact. So think about who you can reach out to and who you can start having those conversations with. And then, as Tammy said, the need for widespread policies to support harm reduction in practice. So sometimes for those people that want things a little bit more structured, or for professions that are dealing with harm reduction in a way that's a little different from, say, a social worker, they may want to have some more policy structured around that. So it's something for us to think about as we move forward regardless of what system you're in. And with that, sorry for talking fast and rambling, everybody. Thank you for being here. And I'm going to pass it back to the moderators for the question period for those of you that are still with us.
Thank you, Taylor, for cluing us up. And because we are a little tight on time, we don't have very many questions, and I'm sure the panelists will be more than happy to answer your questions if you wanted to reach out to them directly. So our goal today was to enhance your knowledge and understanding of harm reduction, offer new insights or lessons that you can apply to your own practice, and encourage those ongoing discussions with colleagues and within your practice setting. And we really hope that you enjoyed this opportunity for knowledge exchange, reflection, and learning. And I think today really highlighted what healthcare professionals need to consider as it relates to addiction and harm reduction. So thank you again to our wonderful panel and for sharing your knowledge, expertise, and experience with all of us today. And to assist with planning for the next CRNNL, NLCSW, and the CLPNNL education session in 2026, we are asking that you complete the evaluation form before you leave the webinar. And social workers attending this session may claim 2 CPE credits under the workshop category as per the college's continuing professional education policy. And if you're a registered nurse or a licensed practical nurse and still require a couple of hours before the renewal deadline, which is March 1st, you can log this as 2 hours under My Learning in the Alinity member portal. And also note that the recording of this webinar will be added to our college's respective website in the coming weeks. So I hope everybody has a wonderful afternoon, and thank you so much for your participation.